Okay, all right. So that's a very important talk. And Steve was just making fun of me because I love to eat half my sandwich. I really do. But then I always eat the other half about 3 minutes later because I just can't wait. So it never works out. All right, but this is going to be a very specific talk about these types of medications called SGLT-2 inhibitors, and that's a mouthful, that are new oral medications that have just been approved in Europe for the use in type 1 diabetes, and it remains to be seen if they'll actually be approved here. That being said, that these meds are approved for people with type 2 diabetes. So a lot of people that have type 1 already, are taking them here. So is anybody currently on one of these medications? Okay, so a decent number of people. And the way it worked real quick is that, the FDA held a meeting here maybe 6 months or so ago that Steve and I were actually there to kind of help testify, if you will, to get these drugs approved. The FDA brings in a panel of outside experts, there's 16 of them, to weigh in on if these drugs should be approved or not. And at the end of the meeting, they literally vote thumbs up or thumbs down to approve it. 8 of them voted yes, 8 of them voted no. So it was literally split right down the middle. And then the FDA kind of had to make a decision and came back and said, no, we need to see some more data on things like that. So we'll see where that lands. And I'll tell you why they did this kind of half yes, half no. Because these drugs work for sure, but there's some safety issues specifically in type 1 diabetes. And it's about balancing these to get kind of the effects. So that'll all become clear. So what's the deal, as Jerry Seinfeld says? So these are drugs you might have heard about, especially if you know somebody with type 2 diabetes. These are drugs that we're using all the time in type 2s now, that they're becoming almost kind of our first medications that we reach for because they work really well. They're pills. They help people lose weight. They have cardiovascular disease protection. There's a lot of good things going on with these drugs in type 2s. Invokana, Farxiga, where they come up with these names, you never know. Empagliflozin or Jardiance is another one. So there's multiple of these types of medications that are available. And real quick, how these work. And I'm actually not even going to talk to this slide. I can just tell you how these drugs work. So basically, we know that the kidneys are always filtering glucose, right? And it's only when our blood sugars get really high that our kidneys kind of can't keep up and that the glucose actually comes out into the urine. So we've always been taught that if you have sugar in your urine, that's kind of a bad thing. But what these drugs do is they purposely block the kidney's ability to kind of reabsorb that glucose. So it specifically makes you pee out glucose, which sounds like a weird kind of way of addressing, diabetes. But the idea is if you're peeing out more sugar, that brings your blood sugars down because it's kind of like this offset valve where you can, get rid of a lot of the sugar. And when you pee out glucose, not only is your sugars better, but it's a little bit of a diuretic, so people's blood pressure is a little bit better. And people tend to, when you pee out glucose, you're peeing out calories, so people tend to lose a little bit of weight also. And that is important for people with type 1 diabetes. I think part of the problem is that when people think about type 1s, they think about little kids that are all, fit and thin. But the truth is in the US that 2/3 of type 1s are either overweight or obese. So we struggle with weight just like everybody else does. And not just like everybody else does, but with other things that make it harder to lose weight. We get low. We like to eat everything when we get low. We have to take this insulin injections that can cause weight gain. So the way that these medications work is basically making you pee out sugar. It doesn't make you pee more. It's just every time you do go to the bathroom or pee, some glucose comes out of it. So people are like, am I going to be, wetting my bed or what's going on? No, you just, you get the extra benefit of losing some glucose. So why would you take it? And this guy's saying, what's in it for me? Well, let me tell you. So your blood sugars are better. And I'll give some data, but the blood sugars improve, slightly. People's A1Cs tend to come down about 0.5% or so. So it's not like you're going from 11 to 7, but it helps a little bit. People do lose weight, maybe kind of 3 to 5 pounds. Less insulin, and I don't really get hung up on how much insulin I take, but basically you get kind of better blood sugars with less insulin. It lowers your blood pressure a bit, so maybe 3 to 4 kind of points, millimeters of mercury, and more time in range. So you get all these kind of benefits. So I like this picture. You're in 10 cents, So So how much sugar are you peeing out in a day? This is kind of what it would look like if it was actually sugar cubes. So it ends up being about 80 to 100 grams of sugar that you're actually peeing out a day, and that ends up being about somewhere around 400 calories a day, which is a significant amount of sugar and calories that you're actually losing every day. So what happens in change in A1C? And these are a couple, as Steve says, doctor slides. That basically these are people that took this drug for about 6 months or so. The red line is what they did if they were on placebo, so they weren't getting anything. And then these other lines is if they were on these different doses of the drug. And what you can see is that in general, people lower their A1C by about 0.5% or so. But kind of jumping ahead, yes, we all want our A1Cs lower. But being on these medications, what the real thing that people like about it is that their blood sugars are better with less work. Because you're peeing out the glucose instead of spiking to 250 after a meal, you might only spike to 180 or 200. So it just seems easier to kind of stay in that range with these kind of once a day pills. So lowering your A1C is great. Here's changes in weight. Again, red is placebo, and then blue and green are the study drugs. These are actually kilograms. So 3 kilos is about 6 pounds or so. And I would say most people would be happy with losing, 5 or so pounds. If you are already thin, it tends to not make you lose as much weight. So if you're lucky enough to be thin, it's not like you're going to waste away and become anorexic. So it tends to be the more weight you have to lose, the more you kind of can lose. And all these studies are in type 1. So people losing weight. And honestly, when people take these medications, they tend to eat a little bit more. It's almost like you can get like a little bit kind of looser with your diabetes and eat things that you didn't used to eat. So being a little bit lazier with your diabetes, losing some weight, and having better blood sugars is pretty helpful. Real quick on this is just how much insulin people are using, and the bottom line is that when going on these meds, they use about 10% or so less insulin. This is more important if you're coming into one of these medications already with a pretty tight control. So if you're starting with an A1C of 7 or so, you might definitely have to back off on how much insulin you're taking. If you're starting with 8, 8.5, you probably wouldn't have to change at all. Now, what about time and range? So since we're making a big deal about this, so let's just focus on this. So again, this is people on placebo. This was a lower dose of this medication, sotagliflozin, and the higher dose at baseline when they just started the study. And you can see the time and range is in green, 12 hours. The time high is in yellow, 10 hours. The time low here is about 1 hour. And this is after being on the drug for about 6 months. Now, what you can see is that you get a pretty significant increase in time and range. It says almost 3 hours a day, increased time and range. And importantly, that's really being kind of like stolen from the hyperglycemic part of it, with no change in the hypo part. So people are having less highs, more time and range, and not an increase in hypoglycemia. There's actually maybe some data showing that when people go on these drugs, they have less hypoglycemia. And I think the reason for that is that, if you have less spikes after a meal, you're less likely to do the correction and go low. Just, when you're staying in range, it's sometimes easier to not go low. So this is kind of summarizing all the benefits that, your A1C can come down 0.4, 0.5. You get a 3-hour increase in time and range. The time and hypo, no change or maybe some reduction. You little less insulin, lose some weight, better blood pressure. On this patient-reported outcomes, just meaning, do people like these medications? And the general answer is yes. I bet if we ask the people that are here on the medication, obviously there's a reason why they're taking it. So, but summarizing, why do people like it? It's really better blood sugars with less work, which is kind of the name of the game in general. That if we didn't have to work so hard, that would be great. And you can eat a little worse and lose weight. To be honest, is that people kind of take advantage of that. Is that, gosh, I'm losing weight and I'm going to liberate my diet a little bit. Maybe I'm going to eat a little bit more carbs than I used to, which is awesome. And I have this mic drop because that's a pretty big deal. But you could take a medication that would make your blood sugars better, and you could eat a little bit worse. That sounds really pretty fantastic. Now, I should highlight that a part of the problem with this medication getting approved is that people really just looked at the A1C. And I said 0.3, 0.4%, why would we approve a drug that has this kind of insignificant change in A1C? But it really is this combination of effects. losing weight, just kind of the ease of of how you control your type 1 diabetes. But this kind of thing is really hard to capture in data, how people feel, how the burden of type 1 diabetes is impacted. So when we were at the FDA, we kind of thought they didn't get it. But what's the catch? So what's the downside? What's the concern? And I have Steve Harvey here. It says the main side effect is, and what's the main problem that we noticed, is that there was a slight increased risk of diabetic ketoacidosis for people that went on these medications. And so about 0.5% of the people on placebo had an episode of DKA, but when they were on the medications, that went up to about 4% or so. So this is where you can kind of have fun with statistics, and it depends on how you want to kind of slant this. You could say, well, that's not that big of an increase. It only went up 3.5%. Still 96% of the people didn't have DKA. Or if you want to be on the glasses half empty side, you could say this was an 8-fold increase in DKA, which makes it sound much more dramatic. So it's just the way that you kind of look at this. All right. So now, why did people go into DKA? Why? And there's been a lot of kind of research around this. Why did people go into DKA? But let me ask you this. So what would be your first signal that you were going into DKA or you had a problem? How would you know? Yeah. You look at your CGM and it would say something that your blood sugar is high. So you would know, okay, I have a problem. I need, maybe my infusion set fell out or I didn't take my insulin. Why is my blood sugar high? I need to triage this problem. But the issue when you're on these medications is this. So what this study is showing is that they had people for 6 hours that were on insulin pumps, and they brought them into a research unit and they basically just took off their pump. And they wanted to see what happened to their blood sugars and their ketones when they did this. And after 6 hours, people that weren't on the medication, their blood sugar went all the way up to 300 or so. So this is all of our experiences. Your pump falls out, your blood sugars start going up to 300. You say, oh, I'm not getting insulin, I need to do something about it. And people, when they were on the drug, though, after 6 hours of not getting insulin, their blood sugars were 194 because they're peeing out some of that glucose. So in a way, you kind of lose your biomarker or your ability to detect that you might be having a problem of not getting insulin. Because my blood sugar is 194, yeah, I'll probably give myself a little bit of insulin, but I'm not keyed into that I might be having a real problem. So this is it's not that the drug's doing something bad. It's just that people can lose sight of when they might be having a problem. And the people that went into DKA tended to be the people on pumps. So I think exactly this was happening. That their infusion site kinked or it fell out, and they just weren't aware of it because their CGM wasn't alarming or whatever. So why DKA? You may not be getting insulin, but your blood sugars aren't that bad. So you're just not aware of it. So you lose insight into when you might be having pump issues, etc. So if you do want to take these medications, and you can, obviously there's people that are taking these, because they're not approved means that they're off label, but your physician can still prescribe them. It might be difficult to get them covered, but honestly, we seem to be able to get them for people. Let me do questions at the end. So you can do it. We prescribe medications off label all the time. And honestly, people are not even aware of it. It's just, when it was officially indicated for or whatever. Does anybody take gabapentin for neuropathy? Have they ever taken it for neuropathy? Few people. That's not approved for neuropathy, but it's one of our, kind of mainstream drugs that we use. So it doesn't mean it's completely off limits. So if you want to take it and you want to stay safe, how can you do it? So I would say start and stay with probably the lower dose. So there's actually four available SGLT2s on the market. They all come in 2 doses, a lower dose and a high dose. I would start with the low dose and probably just stay there. In the clinical trials, the people on the lower dose, they didn't have quite as dramatic effects on their blood sugars and things like that, but they did have the lower risk of DKA. So the second tip is actually to buy a ketone meter and learn what the results mean. So I don't even know when the last time I checked my ketones were. I mean, I just don't do it because I know if I look at my blood sugars and things like that. But if you are on one of these medications, you need to actually be aware that if you are making ketones, so buying one of these meters is important. And they do sell these. They're just kind of like our glucose meters. These are becoming more popular with these ketogenic diets and things like that, where people are actually trying to target ketone levels. So I just went on Amazon and you can buy this precision, I think it's an Abbott meter that does glucose or ketones for $36. And then you have to buy the strips, which are pretty expensive, but you can get 30 strips for about $30, and that's all you'll really ever need, because I'm going to tell you when to test, but you basically only need to test if you think that you might be having ketones, you're feeling sick, things like that. This is just a good kind of safety thing. So when you get the ketone meter, just check a couple times fasting to get an idea of how to use it, what maybe a normal level is. We're not used to, we all know what a good blood sugar is, but we don't know what a good ketone level is. So with that, what do ketone levels mean? What is good? What is bad? When should I worry? And if you want to take pictures of this or just kind of write it down, but basically, it'll be online. Less than 0.6 is good. Between 0.6 and 1.5, you might be having some ketones. And if that's the case, you're going to want to give some insulin, an injection, change your pump site, check your blood sugar and ketones every 1 to 2 hours. This is just good kind of DKA management in general. If you're not on one of these medications, I think that it's probably a good idea to have one of these ketone meters, because who wants to like pee on those strips? It's just kind of gross, and then it's like harder to read them. And so this gives you a very accurate number, and it's something we're all very familiar with doing. So having these around is actually pretty helpful. And then you're going to want to take fluids. So the important thing is, if you do have ketones, you're feeling ketotic at any point, give yourself an injection through a pen or a syringe, because the problem is likely your pump. So a lot of times people this happens to me every once in a while. My blood sugars, I have my pump on, my blood sugars just start going up and up and up, and I'm bolusing through my pump and it's just going up and up. And I don't know why, but I'm not getting insulin. And a lot of times I can't figure out the reason. So taking off that infusion site, giving yourself an injection through a syringe, you're getting that insulin, and then try to kind of start over. And then if your blood sugar or your ketones are over 1.5, that's a problem. Do all the things that I mentioned above. But at any point that you feel like you're having ketones, you're feeling sick, if you start vomiting, that's when to go to the emergency room. So up until that point, you can usually kind of triage it, take insulin, drink fluids, change your pump site, make sure you're feeling okay. But if you start throwing up, that's when you need to go kind of into the ER. So to make that simple, vomiting, emergency room. Yeah. So tip number 3, when to check these anytime you have symptoms. And I think another problem with these medications is that people think that, DKA is only a problem for quote unquote bad diabetics. And I know what I'm doing and I don't have DKA. But the thing again about these medications is it can happen to anybody. So being reminded of what the symptoms of DKA feel like, you just feel awful, you feel nauseous, you get the dry mouth, you get muscle aches, I say flu-like symptoms. If you're feeling off, just check your ketones, and that can help clue you in. So other things to keep safe: avoid super low-carb keto diets if you're on one of these medications, because the point of these ketogenic diets is actually to raise your ketones and to kind of make you in that borderline DKA area. And so you're kind of just closer to the edge if you're on one of these medications. So when I say low carb, what do I mean? I just mean you need to eat enough carbs at each meal to require some insulin, that you want to be taking a unit or two kind of whenever you're eating. So that's important. Next tips: I wouldn't start if your A1C is above 8.5. Just because there's probably a situation where you're not getting enough insulin to begin with. So you want to kind of make sure that you address that first, get your A1C down, make sure you're bolusing and everything. Then you might want to start taking it. I would not take this when you're sick. I would never, omit insulin doses. Sometimes people will say, gosh, I eat and my blood sugar just doesn't go up, so I'm just not going to take insulin. But you always need to take some insulin. And then when I say you may consider some basal insulin, this is a tip that we've talked about in a couple different ways, this quote-unquote untethered regimen, where you might take, let's say, 10 units of Lantus or Tresiba every day as a basal, and then take the rest of your basal through your pump. So that way you're guaranteed that you're always getting some amount of basal insulin. This is really helpful for athletes and people that are in the water a lot too, that you can just unplug your pump from time to time, but know that you still have some basal amount of insulin. So that's kind of a fun thing to kind of play around with. We just did a family vacation in Hawaii, and I did that because I was in the water a lot, but I just started taking about 60-70% of my basal as a shot. That way I could get out, just take off my pump and go in the water for hours and know that I wasn't becoming ketotic because I didn't have my pump on. So now I have this thing that says, hold me, I'm scared. because you probably forgot all the good stuff I started with in the beginning and now are kind of worried about this. But keeping it in perspective, again, that the number of people that had DKA was very, very low. I actually am a big believer in these medications because I think, again, they're very easy to take. The side effect profile is actually, it's not too hard to take these medications, and people really enjoy the benefits. Better blood sugars, less work, losing a little bit of weight. So I think if you're interested in this, talking to your provider about it, this is kind of quote unquote controversial because it's not approved yet, but it's something that you can, definitely try. But I would go the extra mile to get the ketone meter, stay safe, and as long as you're aware of this side effect, I think it really can be mitigated. So if you want to start, ask your doctor for the lower dose. Likely to require some kind of prior auths. I've had everything in the world happen. Sometimes I prescribe these for type 1s, they just get approved because they think that we're type 2s or whatever it might be. And sometimes they want a prior auth, and then they'll say things like, have you tried metformin? And you just say, yeah. And then that works. Yeah. And then sometimes they'll reject it, and everything in between. So it's worth kind of trying. And then obviously once these do get approved, if they do get approved here, this process just becomes much easier. I would get the ketone meter and the strips. If your A1C is pretty tight on the less than a 7.5, you'll need to cut your total daily dose down by about 10%. Be aware of the ketone symptoms if you're starting to feel a little bit off. And then I would, before you start on these medications, write down your average blood sugar for the last month. Write down your current weight, blood pressure, all these things. Try it for a month or so and see how much it improves. And maybe it hasn't changed and this medication is not for you. But most people will notice a little bit of difference. Again, a little bit of easier life with type 1 diabetes. So I think what's exciting about this is if these come here would be literally the first pill for type 1 diabetes. And we're learning that, this is not a cure, but there's other things that you can take, other medications that can help us improve our blood sugars outside of insulin. And I think we've been a little too insulin-centric for too long. We saw that some people take Similan, but we know that there's medications that can help people's blood sugars. And this is another example. So I'm, curious what people's thoughts are of that are taking these medications, but I bet they're positive. But I need to stop there.